have Dr. Padma. Dr. Padma is from Narayana Netralaya. She is the head of uveitis services, and she'll be talking on top 3 mistakes in the treatment of uveitis. So as I said earlier, this instruction course is purely case-based, and we want you to just pick up the key points from the simple cases that we see every day in our clinics. So we see now Manisha entering. Manisha will be talking on top 3 mistakes in diagnosis of uveitis. So we have split up. So over to you, Padma.
Good afternoon to all of you. Thank you, Dr. Reema, for the opportunity. I'll be talking to you of mistakes in the treatment of uveitis with a case example. Corticosteroid is a gold standard in controlling the inflammation, whether it's an infective or inflammatory. But however, if it's not used in appropriate terms, it can lead to complications. Whatever the route in which we administer, either it could be topical or periocular or systemic use. We'll start with the case 1. Here is a 38-year male presented with complaints of recurrent anterior uveitis in 2012. Was using steroids on and off, associated with increase in intraocular pressure, for which he was using anti-glaucoma medication, that is combination of brimonidine and timolol. Best corrected visual acuity is 6.6 and N6. With the medications, intraocular pressure was under control. In the right eye was absolutely normal. The left eye shows the central keratic precipitates, the flare, and gonioscopy angle was open. Fundus was normal in 2012. So we did suspect, in view of central keratic precipitates, which is associated with increase in intraocular pressure, viral etiology was suspected, anterior chamber paracentesis was done, negative for herpes simplex, varicella zoster and CMV virus. So we assumed that we ruled out the viral, and we treated the patient with topical steroids and anti-glaucoma medications, had many episodes of recurrences which was managed, and systemic workup was negative. So patient presented again with blurring, heaviness and halos around the eye in 2016. Using anti-glaucoma medication, in spite of that, the intraocular pressure was high. It is 35 millimeters of mercury in the left eye. Fundus examination could see a pigmented keratic precipitates, prominent corneal nerves, AC reaction, cells were 2+. By then, the left eye showed disc changes suggestive of a glaucomatous disc. Again, we did suspect the viral. We did the AC tap. This time, AC tap for the CMV came positive. Confocal microscopy was done for academic interest, which also showed central globular with dendritic and infiltrative pattern suggestive of infective etiology. At this point, topical anti-glaucoma medication, such as valganciclovir gel, was added. So this is the thing. At the time of presentation, PCR was negative. Repeated episodes was treated with symptomatically. But in the second thing, when patient again had a classical features, AC-tap for PCR for CMV came positive. So whenever we have a clinical picture, suspicion of viral etiology, one PCR negative does not rule out the infective etiology. We have to closely monitor them and watch out for this. Once we put appropriate antiviral therapy, it results in resolution of the inflammation. We are seeing more number of CMV anterior uveitis in immunocompetent individuals now. So coming to the learning point from this case, recurrent viral anterior uveitis needs treatment with high index of suspicion. AC-tap for PCR viruses may not be positive in all the cases. We need to repeat the test. Confocal can be used as an indirect measure to show the infective pattern of keratic precipitates in CMV anterior uveitis. We'll move on to the next case. So, posterior supinnon steroid injection and sequelae. Here is a 33-year male, defective vision in both eyes since 1 month. history of fever with rashes 1.5 months back, for which no diagnosis could be made even after being thoroughly investigated, even was hospitalized for that. Patient gave history of scrotal herpes few years back and is a known diabetic. Patient has seen elsewhere. His old records had a picture like this where he had block fluorescence in the early phase with staining and disc leakage in the late phase. So, OCT old record showed hyperreflectivity with aftershadowing effect. So, they thought it could be a fever with retinitis, post-fever retinitis, since he is a diabetic and he had a scrotal herpes. They gave a posterior subtenon injection to control the inflammation. The patient shows when the patient presented to us, he had decreased vision in both eyes. The best corrected visual acuity was 624. AC reaction was there. In addition to that, there were vitritis and vitreous haze. There was an hyperemia of the disc with retinitis in the posterior pole. This is a close-up picture. The left eye also, patient had medium KPs with vitritis with vitreous cells. Had presentation to us, had altered foveal contour, hyperreflectivity with aftershadowing effect with hyperreflective dots was seen with SRF. So this is the old record picture and this is the new presentation picture. Investigations, most of the causes for the post fever was negative. Chikungunya, dengue, autoimmune workup was also negative. Toxoplasma titers were also negative. ACTAP PCR was advised. CMV came positive. This is a nested PCR showing positivity for CMV virus. So we added the systemic valganciclovir and patient received intravitreal ganciclovir 2000 microgram in 0.1 ml. Intravitreal injection of bevacizumab also was given to the right eye in view of CMV. Patient received multiple intravitreal ganciclovir injections, total of 8 injections over a period of 2 months. This is at presentation, follow-up 2 months showing resolving retinitis. So this is a post-treatment picture showing resolved retinitis with pale disc in both eyes. Visual acuity in the right eye was 660, left eye did not improve. So important to check the history of herpes zoster and also the control of diabetes and systemic immune status before administering steroids, either it could be depot or systemic steroids. When one is unsure of the past history, better to avoid periocular depot steroid injection. There is risk of viral reactivation with retinitis is there with the past history of herpes zoster. The next case is systemic steroids without appropriate antimicrobial therapy should not be given. Let's see. Here, third case is a 58-year female diagnosed have a viral retinitis and panuveitis, not responding to treatment, referred for second opinion in 2013. Visual acuity in the left eye was 260, the right eye was within normal limits, intraocular pressure was normal. This is the old photograph at the time of presentation. Patient had a diffuse pigmented keratic precipitates and vitreous haze with suspected focal areas of retinitis. Based on this, the primary ophthalmologist thought it was a case of a viral uveitis. Treated with antiviral and steroids, patient did not improve. So at the time of presentation, there was keratic precipitates was slightly better following the steroid therapy. However, there were pigmented keratic precipitates was present. On fundus examination, media haze, hyperemia of the disc, we could see multifocal retinitis with involvement of the arteries, something what we call it as arteriolitis kind of a picture. At this point of time, since the patient showed worsening and also retinitis with arteriolitis, we thought could it be a toxo. OCT shows the presence of ERM with hyperreflectivity of the vessel corresponding to the sclerosed vessel with retinitis. Serological titer was strongly positive. IgG was 500 IU per ml. ACTAP for PCR came positive for Toxoplasma B1 gene, and confocal showed central globula with dendritic pattern of keratic precipitates. We started the patient on antitoxo treatment, sulfapyrimethamine and folic acid, followed by systemic steroids with topical steroids and cycloplegic agents. In view of extensive involvement, we gave intravitreal Clinda along with dexamethasone was given. So following which we could see the resolving retinitis in the left eye. So this case illustrates a possible consequence of systemic steroids and infection with toxoplasmosis, because here the steroids was given without appropriate antimicrobial therapy. Similar case have been reported by Kleherush et al. So it's important to rule out toxoplasmosis in retinitis case. They may not have classical headlight in the fog with significant vitritis. We do see atypical cases. So molecular diagnostics can help us to confirm the diagnosis in atypical cases. We need to start antitoxoplasmic treatment followed by systemic steroid therapy. If we have a time, I'll go to the next case. So case number 4. Whenever we are treating with uveitis, if the patient is not responding to the treatment, we have to watch out for other findings or complication. What are the missing things? Here, 36-year male, known case of seronegative arthritis on topical and systemic steroids. Patient did not improve. There was a worsening of the vision. So that's why the patient was referred to us. On examination, we could see the anterior segment inflammation. And in addition to that, there was significant vitritis and macular edema was also present. So we wanted to know what is happening, why he is not responding. The fundus examination findings were not classical, but when we did the OCT, it showed serious detachment, something like a CSR kind of a picture. So we did the FFA, which showed classical smokestack appearance of a leak. Because this particular patient has associated CSCR, that's why following stepping up of steroids, there was a worsening. We tapered the steroids, then we introduced the systemic immunosuppressive therapy, following which we could see the resolving CSCR. However, when tapered the steroids, there was worsening of the inflammation. So we have to balance between the two. Learning point: to watch out for the response to therapy. Whenever the patient is not responding, our antennas has to go up to find out any other associated changes happening. So without analyzing the case, we should not increase the dose of systemic steroids. Multimodal imaging can help us to find out the underlying associated diseases like CSCR or in choroiditis, choroidal neovascular membrane. These are the things we need to rule out. So retinitis is most commonly associated with infection. Atypical multifocal retinitis, in addition to serological, molecular diagnostic can help us to find out the etiology. Systemic steroids should be started only after appropriate antimicrobial therapy in a case of infective uveitis. Non-responder, we need to look out for complications or associated changes in the eye. Thank you for your attention. Any questions, I'll be happy to take it up.
Thank you, Padma, for the wonderful cases.